all. It's very difficult to deliver a talk on post lunch session and extremely difficult for the audience to listen that. Diabetic foot is very underestimated and under observed complication of diabetes, because as a diabetologist I always say that we are not managing diabetes but we are managing complications of diabetes. The people are not aware about what the glycemic load will damage their vasculature, their fat tissue, their peripheral vasculature, as well as the neurologist. Uh, this all damage ultimately leads to many complications, but we talk about cardiovascular disease, we talk about stroke, we talk about fundus examination, we talk about CKD, but rarely we talk about diabetic food, which should be one of the most important, and that is why I am talking about building an integrated food care team, because this is very important. And me and Dr. Bansi sir discuss and we plan this important food symposium, and I would congratulate all of you to be here and we together learn many things. This is a stark reality. Why? Because 1 year mortality after major amputation is around 30%, and 5 year mortality after major amputation is around 60%. And this gives us gravity that if 10% has a major amputation, only 7 will survive after 1 year and only 4 will survive after 5 years. And also those who survive, they have very high rate of re-amputation and recurrence. The recurrence and re-amputation rate at the 2 year it is 19 to 31%, and at the 5 year there is 37 to 50%. So re-amputation recurrence rate is very high. But in talking in terms of mortality, we can say that major amputation has high mortality than many other cancers. Only lung cancer is beating the major amputation. Otherwise amputation can affect life morbidity wise as well as mortality wise. So this is why we need an integrated team. Because diabetic foot is a multifactorial disease, it has a neurological dysfunction, vascular dysfunction, infective causes, pressure points, and social factors. So not only one specialty can address this problem. Most of the time when we are talking about insulinization in India, we tell that doctors are very busy and they don't have 10 minutes extra to educate the patient about insulin, because once you tell patient that there is a requirement of insulin, you have to be mentally prepared that you have to spare 10 to 15 minutes extra. And same thing happens with foot ulcer. The 90% of the clinic, they don't examine foot, and if they start examine food, they will understand that they need a good team to manage the diabetic foot. So integration ensures better survival and limb salvage. Is there any evidence that multidisciplinary team has better output than a single doctor? Yes, there is evidence that there is around 60% reduction in major amputation if the multidisciplinary team is managing this kind of foot ulcer. So who can be the part of this core team? A core team is actually very essential, and it includes first of all diabetologists. A diabetologist is managing not only diabetes, but he is one of the most important person in managing diabetic foot, because the patient annually at least visit diabetologist for 4 times, and there are 4 chances with the doctor that they can prevent any diabetic foot ulcer. It starts with screening. They have to observe foot of all the patient, and we have to see that whether the foot is a normal foot, whether it is a high risk foot, whether there is some ulcer or infection or gangrene necrosis, or there is a need of amputation. So diabetologist is very important to screen the person with diabetes, because they are the regular touch point of the patient with diabetes. Second, if the person is having high risk foot or already some ulcer, there is a need of podiatrists for specialized foot care, including wound debridement, offloading, and orthotics. Now, physiotherapist is also very important part of management of diabetic foot, because biomechanical assessment as well as the exercise planning for the patient is very important. So physiotherapist must be there. There is a many time vascular insufficiency, and at that time vascular surgeon's role is very integral for assessing and managing the vascular issue. Orthopedic surgeon is very important, because when there is some abnormality or some bone issue with foot or ankle, the surgical intervention and managing foot and ankle problem by orthopedic is very essential. Diabetic nurse specialist for patient education, wound care, and monitoring is also important, and ultimately after doing every intervention they require proper footwear and orthotic device, and therefore the orthotist is a very important part of core team, and this team must work in alignment for better outcome in person with diabetic foot. What could be the workflow? The start with the screening. As I already mentioned that from a normal food to amputated food, there are 5 steps that can be helpful if we evaluate them properly. First and most important is whether the risk food is a high risk food or normal food. At every visit, we have to do charan spars of our patient and see whether the food is high risk or not. Second thing, whether there is ulcer area or not. If ulcer is there, it should be addressed properly. After ulcer, then we have to see that there is vascular insufficiency or not. That we have to evaluate, and also we have to evaluate for infection, whether the wound is infective or not. And ultimately, we have to see whether there is a gangrenous fit or not. And according to, we have to make the triage of the patient. Once you triage the patient in different category, then there is a role of multidisciplinary team for management. If you require physiotherapist, if you require vascular surgeon, if you require orthopedic, and if you require podiatric, you have to involve accordingly. 4 major steps that must be taken in any management of diabetic food. First is a revascularization. If there is vascular ischemia, none other treatment will work rather than re-establishing the workflow, blood flow. So revascularization is very, very important. Second is debridement. If there is a dead tissue, you have to properly debride and allow the good tissue or healthy tissue to grow. Third thing is offloading. Pressure points are very important to remove. If you have to understand the pressure point, and you have to do offloading for better ulcer healing. And antibiotic, we have to do culture, and according to sensitivity, we have to provide antibiotic for better healing. And ultimately, once the foot is managed, we cannot allow the patient to live. Otherwise, we have to do rehabilitation and follow up regularly to prevent any other complication in future. So let's start with the screening. The screening starts at every visit of a patient to the clinic of diabetologists, and diabetologists must do routine food examination. If the facilities are available, they can do ABI and Doppler. Otherwise, 10-gram monofilament testing and tuning fork is also good to go for a basic screening of diabetic foot. Then vascular assessment. If required, CT angio for peripheral arterial disease dissection, early referral for revascularization improves outcome, and that should be done whenever it is required. Offloading is the cornerstone. Total contrast contact cast is a gold standard for management. Removable walker, therapeutic footwear are also some alternative, but they had to be done by specialists. So podiatrists must be a part of your team and let them do their job. We should not interfere in that. So footwear and orthotics, custom install orthotic footwear, pressure redistribution prevents recurrence. Talking about debridement and dressing, it should depends on times, what type of tissue is involved, whether it is inflammatory or infective. Moisture balance must be maintained, age of the wound should be evaluated and cleaned properly, and surrounding scene also see for infection or any vascularity. So regular surgical debridement is also very, very necessary, and moist wound care dressing based on exudate should also be done. Infection management is very important. As and when required, we have to take a swab and send to a pathology laboratory for microbial evaluation, classify the severity, and culture guided antibiotic must be given. If there is a mild infection, oral treatment will be sufficient, but if there is a moderate to severe infection, IV treatment must be a part of your therapy. Now coming to a basic management of diabetes, a systemic control. Good glycemic control is of paramount importance of management of diabetes. But I must say that only management of diabetes will not work. We have to manage the patient's weight. We have to manage patient's lipid profile, we have to manage patient's blood pressure, and also we have to stop smoking or any other tobacco in any other form. So management must be a holistic, a full metabolic management, cardiac, renal, metabolic, liver and obesity. Everything must be managed properly with the help of team of diabetologists for systemic control of diabetes. Rehabilitation and prosthetics. After a proper management of wound ulcer, we have to educate patient for physiotherapy and gait training at home, and if required, a prosthetic support for amputees must be given. Education is one of the important pillar in management of diabetes as well as diabetic foot ulcer. Daily self-infection, we have to educate the patient every time, and hygiene must be maintained, and whenever required, a family member's involvement is very, very crucial in this management. You have to audit and quality metrics for your team. What is your healing rate, what is your amputation rate, and what is your survival rate you have to have for your clinic for a better outcome. If there is a multidisciplinary team, it reduces the hospital stay, reduce hospital cost, and also disability burden. So it is ultimately will become a cost effective. So practical roadmap for integrated care, I must say that we cannot have every specialist at our clinic every day. So we have to start at least once weekly or twice in a month, that every specialist come on a fixed day. On the same time, all the patient must be invited to visit by the consultant. So weekly food clinic is a very good idea. Secondly, when the clinician or a surgeon, orthopedic physiotherapist is not available and patient come in a routine OPD, then you must have your referral SOP. Urgent communication pathway also should be there, and whoever will treat the patient should be referred to them. And also at your clinic, trained nurses and community health workers must also be trained for better management of food care. This kind of a checklist, this kind of a brochure and education material should also help patient whenever patients have a normal food or high risk food. This kind of literature, if you are giving them with your file, they will regularly read that and they will improve their hygiene and also food care. Also, we have to do outreach and education. Community outreach is very important. We have to consider outreach program to educate community about diabetic food care, because it is more lethal than many of the cancers. Staff training is also important. Providing training for staff member and other healthcare professional on diabetic food care should be done. Patients are a paramount important in education system. Offer regular education session for patient on food care, wound management, and importance of early intervention whenever there is a high risk food or there is any initial vascular or infective or ischemic ulcer. Mobile clinic is also good idea. Explore the possibility of mobile clinic to reach patient in a remote area who cannot come to the central facilities. So with that, I would say that diabetic foot problem is not only a problem of foot or ulcer, it's a problem of life and limb thread. If the person has a major amputation, the 5-year survival rate is lesser than many cancer, and only 3% out of 10 will survive that 5 years. So rather than we should focus only on diabetic care or cardiovascular or renal or liver or metabolic disease, we have to be very careful and senseful for managing diabetic foot. A multidisciplinary team reduces amputation and improves survival. So involve physiotherapists, involve podiatrists, involve orthopedic surgeon, vascular surgeon, diabetic nurse, and an educator in your team for a better and good outcome. Offloading, revascularization, and infection control, they are very core pillar. Every person you have to offer offloading whenever there is ulcer, and this is a work of podiatrists or physiotherapists. You cannot take that task because you are not having enough time to educate your patients, so you should not waste your time. Revascularization, again vascular surgeon must be in your team and evaluated and treated properly. And infection control, if there is infected food, the culture should be done and treatment should be done accordingly. Prevention is the most important key for the management of foot amputation for diabetic population, and we have to educate. Education is the key for the prevention. With that, if there is any question, we can take at the end of the session. Yeah, thank you so much.